Good afternoon, everyone. I'd like to introduce myself. My name is Ahmed El Fiki. I'm Assistant Professor of Neurosurgery in Qasr Al Aini, Cairo University in Egypt. And we will talk about surgical complications and long-term outcome of bifrontal decompressive craniotomy used for management for cases of refractory cerebral edema following traumatic brain injury. This is the place where I come from, which is the largest tertiary hospital in Egypt with more than 4,200 beds. And our neurosurgery department serves about 185 beds, with including 20 ICU beds. As we know, severe traumatic brain injury is associated with significant morbidity and mortality, representing a major public health problem, considering among the leading causes of death and permanent disability among children and young adults. During the acute phase of TPI, the main goal of management is to lower the elevated intracranial pressure, minimizing adequate perfusion to minimize the risk of secondary brain injury. Decompressive craniectomy is a surgical procedure used to lower the uncontrollable ICP in patients with TBI. The aim of our study is to evaluate the bifrontal decompressive craniectomy used for management of refractory cases of edema following traumatic brain injury. And we will look about the surgical complications. And this is a prospective study conducted between June 2013 and December 2017 in 18 cases. The inclusion criteria include the severe head injury with Marshall classification grade 3 for all cases, which is defined by midline shift more than 5 millimeter, and basal cistern are compressed and totally effaced with no high or mixed density lesion more than 25 cc. And they are not improving or deteriorating within the first 24 hours, despite adequate medical decompression. We excluded the associated injuries that necessitate surgical management, like subdural hematomas, GCS less than 5, and bilateral dilated pupils, and age over 65. We did a bicoronal skin incision, which allows exposure of the frontal and temporal bones. The bone flap is designed to include the frontal bones and aim at time of squamous, also squamous part of the temporal bone. We use a U-shaped dural incision based on the superior sagittal sinus. We did a duroplasty with a precranium orthodontic dural flaps. We removed the bone flap, and we recently start to put them flail also. This is the extent of how much we remove from the frontal bone bilaterally. The total number was 13 of them were males, and they are ranging from 16 to 60 years. The initial GCS was between 6 to 11, and the time of surgery ranging between 5 to 8 hours. We have subcutaneous CSF collection in 3 cases, hydrocephalus in 2 cases, and subdural CSF collection with midline shift in 1 case. And we have 1 case of intracranial infection. The long-term outcome was good recovery in 8 cases, severe disability in 3 cases, and vegetative state in 6 cases, and 1 patient died. This is one of the CSF, this is one of the collections, subcutaneous, and a case of hydrocephalus post-surgery. This is the case of subdural collection, and one of them was CSF, which needed correction of the adherent part of the brain to the skull edge, and the other revealed that it was empyema, which need second surgery for debridement. So to conclude, we got a favorable outcome in 44% in our cases and 1 case of mortality. Thus, we recommend considering bifrontal decompression craniectomy as an effective procedure in lowering the morbidity and mortality in cases of refractory cerebral edema following TPI. The unfavorable outcome seemed to be related to the low GCS on admission and the favorable outcome observed in patients with higher GCS at the time of injury. Thank you, and you are welcome to visit Egypt, of course.